Great, welcome back to Healthcare, a little bit after 1:15. And we have the blueprint with us today, which is pretty exciting, to talk about the community health team expansion that we put in the budget last year. It seems like it was a long time ago, but it was just last year. So John, I'm gonna turn it over to you.
Sure. Hi, everyone. Good afternoon. I'm going to introduce two of our speakers with me. Dr. Addie Armstrong, our Blueprint Data and Analytics and Information Administrator, is going to take over around slide 10. And from the Department of Health, the Director of Family and Child Health, Elisa Stolberg. So thank you both for being here. We prepared this presentation together, gave it at Senate Health and Welfare on February 1st, and have updated it based on the latest information for you all this afternoon. There is a handout that accompanies this presentation that begins with acronyms frequently used by the blueprint that are spelled out, as well as more detailed information on areas that we thought you might have questions, like who was on that committee, when did it meet, what groups were represented, what topics are you covering in your education, and then some very specific updates that we gave you in anticipation of the types of things you might want to know from your area. So here it is. The Blueprint for Health, established in 2011 in statute to promote high quality care that integrates advanced primary care, specialty care, and community-based services to impact Vermonters' health and well-being. It's been supported by multi-payer participation, and the foundation is built upon the multidisciplinary community health teams that provide care coordination and linkages to services across the care continuum. Building on that foundation, the community health team models have expanded in time to the spoke system of care, so office-based opioid treatment and the hubs. So the spokes support primary care and deliver treatment for individuals with opioid use disorder in the form of medications for opioid use disorder, as well as care coordination and counseling. The Pregnancy Intention Initiative, formerly called the Women's Health Initiative, ensures access to services that support pregnancy intention. And new in 2023, and the focus of our slide deck today, is the Community Health Team Expansion Pilot, a 2-year pilot aimed to address mental health, substance use disorder, and social determinants of health within primary care. Since its beginning, the Blueprint has demonstrated results in improving healthcare and managing costs. The annualized rate of growth in healthcare claims among individuals who attend Blueprint practices is 0.3% lower for Blueprint attributed lives than for non-Blueprint attributed lives. And in the context of this effective and efficacious foundation, and given the crisis in care access for those with mental health and substance use disorder, I've included a couple statistics that I'm sure you all have heard about this session, the last session, and in our worlds around us and in our own worlds, that the number of Vermonters with mental health and substance use disorder concerns and issues is higher than it's ever been, and its consequences are. And in our own Blueprint data, we've seen since 2019, even, the number of Vermonters with at least 2 outpatients visits, or claims, as we call them, so for mental health or substance use disorder, increase by nearly 7%. Also, since 2019, the Vermonters with at least 1 claim for psychotherapy services has increased by 11%. And in 2022, over 20% of individuals had a claim for some type of therapy. So what we experience, what we see is confirmed by some of the data that we're able to look at in our claims database. The expansion pilot was really the action that the legislator took to respond to this crisis with the Blueprint levers that exist. So in 2023, the 2-year pilot expansion was authorized, and Act 78 specified for a 2-year pilot to expand the Blueprint for Health Hub and Spoke program. Funds shall be used to expand the substances covered by the program, including mental health and pediatric screenings, and make strategic investments with community partners. And today, through myself, Elisa, and Addie, we're going to talk about the progress report on that investment thus far. I'm going to reel back a little bit to give you all a review of what I presented last year in testimony in terms of what we were hearing from stakeholder groups. So whether you remember, whether you don't remember, I'm just going to give a quick overview of that before I turn it over to Addie to get into the numbers and progress of where those dollars have gone. since July of last year. So in terms of community engagement, the Generating Programming Informed by the current mental health landscape of Vermont began with an intentional effort to engage the community at each step of the expansion process. And we at the Blueprint began this engagement process even before the budget was passed. So we began this work in 2022 by visiting all the health service areas, and we began this work very intentionally at the beginning of last year, pulling together work groups that I'll mention to you and that are very much detailed in the handouts that I had for you. In addition, Chair Houghton is on our executive committee, and we had more than our usual every other year executive committee meetings last year to keep up with the pace of really delivering on this as quickly as possible. Also on our executive committee is an individual with lived experience in statute that's named as a consumer representative, professional societies, community-based organizations, and I said Chair Houghton. There were also, beginning in March and going all the way into June, 3 topics covered in our work groups, design of the program. So what are we actually going to do? Who will deliver it and how? A measurement and evaluation, looking in depth into how do we determine whether this is effective or not? Did it work? Did it not work? Was it implemented? How was it implemented? And then, of course, also once we have these dollars, how will they be paid? What will the payment model, a term I was very familiar with in 2023. I don't think I'd ever been as familiar with that term in my life until 2023. What will the payment model be? How will these dollars go out the door? And that's something that Addie's going to cover. And I show for you the representation we had in those groups and the number of meetings we had there. There were also in July, in 1 week, 3 public question and answer sessions. And I list for you, we had great attendance, and we even had repeat attendees. So 75, 80, and 60 individuals attending from hospitals, practices, providers, payers, and from a variety of settings when it comes to providers. We did them at different times of the day. So early morning, midday, end of day, to try to be as flexible to everyone's schedule as possible. And then looking at what the pilot development could be for the importance of community health teams to improve their efficiency, effectiveness, and resilience, and the importance of screening. And that's something I brought up in my presentation last year, identifying problems that one might not think to ask otherwise in a patient visit, so that people are uniformly asked the same questions at least annually, so that problems can be identified and addressed, if that's the wish of the family and the person, earlier than the very late stages sometimes of things that don't get brought up in a visit. Also recognizing, again, as I said before, the high rates of depression, anxiety, and other mental health concerns within the community, particularly among children and adolescents. We heard that, we saw it, we know it from our partners at the Department of Health, and we know it from our own lives that needs to be a particularly important part of recognition as we roll out this plan for the expansion. And what can be the challenges and opportunities with specialty referrals and community resource needs? How can we look at the right time to refer, and how can we look at evidence-based that shows some concerns can be addressed within that office setting where the person is seen for primary care, and bringing greater clarity to that? So a need for the community health teams to expand with an emphasis on particularly community health workers, social workers, and mental health clinicians, and supporting patients not just with opioid use disorder, but alcohol use disorder, perhaps marijuana, cocaine, the myriad number of substances that can cause use disorders in our communities and in our neighbors and everyone beyond opioids. So to really expand the breadth of expertise in our community health teams beyond that substance. I think I'm going to turn it over to Addie, but yes, I'll take your question, Lori.
Time. So question.
Yeah, it is.
Art?
How much, you just mentioned marijuana. I'm very concerned about it and dislike greatly the fact that we legalized it. Can the mental health problems in children, any of it be directly related to that?
Wow, that's a great question, Art. I'm not up to all the latest literature. The last time I looked at that actually was when I was still a hospice physician, trying to catch up on what was going on in Colorado. So I'm not that up on what the evidence is. I'm not sure whether you want to take that question to the Department of Health
We
or,
don't need
but
to, yeah,
I've certainly followed it in the past. I'm not up on it right now.
Yeah.
In terms of what the Blueprint is doing in our education efforts is to include in our education efforts for our providers information about what that might look like and how to treat it.
All right, thank you.
Brian and then Leslie.
Yeah, so I have a question just about co-occurring disorders and the polysubstance issue. I'm less concerned about cannabis. I'm more concerned about the rise of methamphetamine use being paired with opiate. I'm curious, like what you're hearing or seeing in regards to that appearing.
Sure. Yeah. It's something I've definitely heard, Brian. We just released a request for proposals for education and training that's very expansive and that I detail in my handout so that the vendor that we work with will include evidence-based identification and treatment of not only opioid, but also I use psychostimulants or any type of upper, because that can be an area that should that be treated in primary care? Should that be treated at the, where should it even land? And we want to devote resources to figuring that out community by community. So people don't have to wonder so much, what do I do with this person? I want to help them, but I don't know where the expertise is. And that's going to be an investment of time and expertise. It's going to, yeah, thanks. That's our intention, is to get there.
Oh, thank you.
Leslie?
And then Tyler.
On slide 4, you just
Oh,
mentioned
sure.
that
Let me
healthcare-
just,
Yeah,
sorry. Okay, I'm with you.
okay. Healthcare claims is 0.3% lower for Blueprint lives. And I'm wondering how that translates into an absolute number and is that significant?
Sure. I'll probably leave that to Dr. Armstrong when she gets into more detail of this presentation. A lot of this is her work, and I was giving sort of an overview intro, but she can certainly, yes.
Absolute number.
So I am,
We have one more
oh,
question.
I'm so sorry.
Under the recognition of, we're kind of emphasizing young people, children and adolescents with depression and so on. Can you just talk a little
Sure.
bit about that?
I think,
Because
sure, absolutely.
that's really troubling.
Yeah. So I'm a pediatrician. That's what I dedicated my residency training to when I was still in California. When I lived in New York City, I treated children, and that sometimes went up into their 20s. I think as a leader in this role, Topper, when I say emphasize, it's because it is important and it is on the rise. And also because of my colleagues in the pediatric community, the family medicine community are aware that in their minds, that people in leadership positions around healthcare make children or people at the younger end of the age spectrum like, oh, right, oh, we have to include them too, almost as if it's I'm talking about my colleagues that, well, you didn't start with us. Why weren't we part of the conversation from the beginning? So I think I'm very much trying to bring that awareness to my leadership role with my colleagues at AAP, the Vermont Medical Society, Family Medicine, but also my pediatric colleagues just around the country who I've stayed in touch with, and look at the data and make sure that what we're doing is building in the importance for identifying children, adolescents, very young infants, which we still talk about across really that whole span and up into early adulthood into our program. So that's where recognition comes in for me, the data, the personal and professional experience, both, and making sure that it's part of our planning from the beginning so that we're not repeating on what maybe other people's experience in other states have been of like, well, you didn't bring in the children's emphasis from the beginning. So I don't know if I'm speaking too directly to my experience or answering your question, but hopefully I'm doing both.
Appreciate that.
Yeah. I'm happy to talk more about it if you'd like, but I'll leave it there.
Thanks.
Addie?
Yeah.
I will be back.
Great.
I'll do a little rotation.
It's exciting for us.
Everybody needs to be awake afterwards, right? So one of the things that we wanted to do while we
So
were.
I'm gonna stop you real quick. Can you just give a little bit of your background and how you landed here? Because this is your first time here.
I'm Dr. Addie Armstrong. I'm a PhD in mathematics. I've been an academic. I've been a consultant. I've done everything from operations research analyst work to teaching very young people how to add numbers. So I've done a lot of different things. I came to the I came to AHS in 2022 in the Money Follows the Person program, where we were focused on getting people out of nursing homes and back into their own home or into a residential setting of their choice. And I was able to do a lot of great work with that. And then that is a limited service position. So when this position opened up with the Blueprint, I said, that continues the stuff that I'm really passionate about. When I was 16, I became an LNA. And so obviously there's some healthcare in my background that I'm really interested in. And then the math side was like, oh, I can apply both of these at the same time. So that's what brings me here today.
Great.
And I'm very excited to talk to you about the data, but not just that, because the stories are where the heart is. So I will be speaking a little bit to both of these things.
Great,
So
thank you.
you're a doctor of math
I am.
and you're a doctor of medicine. Yeah, just want to clarify.
Different kinds of doctors.
Yes, yeah, different kinds of doctors, yes.
That was hard.
Yes.
I'll send you to him.
If I can't afford it, I'll come to you.
And I'll reach your estate while you're on there. So while we were designing the pilot, I and all of us really wanted to not just do something that was popular, but do something that worked. Because it's great if we have all this feedback that says, please change these things, but if those changes aren't going to impact anything, that doesn't help. So we got a data extract from our VCures, which is the Vermont All Payer Claims Database. That was 4 years of claims data from 2019 to 2022. We were doing this in 23. 23 wasn't over yet. You understand why it's not that current. And individuals were then categorized from that data set into either being a Blueprint primary care attributed person, meaning their primary care physician is affiliated with the Blueprint, or being a non-Blueprint one. And that gave us kind of a control group and a non-control group to really look at and compare the differences between what's going on. We also categorized these individuals into a mental health substance use category if they had at least one inpatient or 2 outpatient claims with specific diagnosis codes in the past year and the year before that. And those diagnosis codes, I can get you the list. It's a giant list. Nobody really wants to read it. And
Well, maybe you do.
Love code.
We did exclude the codes related to things like developmental disorders or dementia, things that really wouldn't fall under the category that we were kind of addressing with this expansion. So reviewing that data is quite fun. The first graph we have here is individuals in the mental health substance use category over the past 4 years. And the blue line is the Blueprint and the dotted green line is non-Blueprint attributed patients. And so as you can see, the Blueprint has a higher proportion of patients with a diagnosed mental health or substance use condition. And it's growing faster than the non-Blueprint attributed lives. And that can be due to a number of reasons. It doesn't look like a very big difference. 26.5 to 28 is not a very big difference, but it is a statistically significant difference. And that matters to us. So statistically significant means likelihood of random or not random. Is this just like, well, it happened that most of the people turned up here? It is statistically significant at the 0.01 level. That means there's only a 1% chance that's random. So we think this is a real trend. We're interested in it. So that's telling us, okay, yeah, focusing on expanding services at Blueprint practices will address this population and at least reach them to some extent. Other things that we wanted to look at is what we're doing working at all? Should we do more of it, or should we change and do something completely different? On the left-hand side, you'll see the per member per year medical and pharmacy claims costs, so the total dollar value of claims submitted per person in the average year. Blueprint, again, stays as the blue line, and non-Blueprint is the green dashed line. So Representative Goldman, I think you asked about that 3%. That is a growth rate. So every year, claims grow a little bit faster for non-Blueprint attributed patients. And here is that difference you were looking for. It's currently about $2,500, $2,600. So it's worth it. We're doing something right. That's what I always like to say is something is significant here, and it's increasing. It'll level off and change over the pandemic years and whatnot, but we do have a difference. The graph on the right here is one that I'm particularly fond of. It shows the proportion of individuals in the mental health substance use category who had an ED visit for anything at all. And so we in no way expect people to have no ED visits. If you hit a moose, please go to the ED. If you break an arm, please don't try to get that out of your primary care physician. But Blueprint mental health substance use patients are visiting the ED less. And that's actually a good thing, because some conditions can be treated out of the ER. And when they can, we want them to be. We want the primary care to be the first point of contact. So that's a great thing. That's another one where the difference is small, but statistically significant at the 0.01 level. So we care. It appears that this is not a coincidence. It seems like we're actually making a difference here, which is exciting. Another question, and this was really important, is who is the Blueprint community health community? Is it all Medicaid patients? Is it all Medicare patients? Is it all children? And this is our latest quarter of reported by the community health teams themselves, who they saw, what kind of insurer they had. Basically, we're seeing everyone in about equal proportions and about what we would expect. Medicaid was about 29% of the population. Medicare was about 30% of the population. And then commercial insurers, were 26%. I will note on that, that's the big three. That's Blue Cross Blue Shield, MVP, and Cigna, because those are the three biggest insurers in Vermont. And we do not track all the littler, smaller insurers. So the little smaller insurers might be also in that other category. Small insurance plans, non-Vermont Medicaid, uninsured completely, don't have medical insurance, things like that. Also encouraging, that means if we expand community health teams, we are going to reach everyone. We're not just reaching one group. We're not just targeting one area. So very encouraging there in that area as well. So with all of that information, we know that community health teams reach the people we want. We know that we have a mental health crisis. I'm just going to use the word, that's the word. And we know that we can make a difference and the Blueprint has worked. So what are we going to do? We're going to try to make it better. We're going to try to make it bigger, make it better. And that's thanks to you guys for pushing that through and giving us the money to do that. So what do we want to do? We want to take a multi-pronged approach. Expand the community health teams. They serve everyone. They are the boots on the ground. They are getting this work done. So we want to increase the availability of screenings, increase the availability of a brief intervention or navigating someone to services. We all know it's a very complicated system that we live in. We need to be able to do those things. We want to expand the educational offerings. Dr. Soroyan talked a little bit about that earlier, about how we want to enhance, not just opioids, but marijuana and methamphetamines and psychostimulants and all sorts of education offerings that we have around these things. We want to enhance quality improvement facilitation. We're introducing new people into practices. We want to make sure that they have the support they need to really incorporate those new individuals and do that in a number of ways. And we also want to encourage partnership with our community partners. We want to make sure that we're hiring through a designated agency or a parent-child center and really integrating this level of care across the community. Education and training, we kind of touched on this, so I might go a little faster through this one, but we do have the CARE series, which is monthly webinars. They will be wrapping up in July of 24, and we have a whole ton of topics: alcohol use, lethal substances, beyond opioids, all sorts of things there. There's an even longer list in the handout. You can enjoy those. You can visit the website, maybe drop by some of the sessions. It'll be fun. And we also have an in-person conference coming up in June that we're very excited about that is specifically focused on substance use and mental health care. We are send out an RFP for the next year of training. We're not stopping in July. We have another whole year of this. So we have an RFP out. We hope that will start in August. And there's a ton of topics that we want, at least 16 sessions, more topics, including some things that we might not think about, like de-escalation. When you're dealing with someone who's in crisis, how do you make it so that they're not targeting you with that? Things like that. The community health team expansion itself is really where I want to focus, because that's where we're dumping most of our effort right now. And it's expanding the CHTs by providing more staff. We know that it's hard to get people to do this work, and it's hard to fund people to do this work. So that's where we want to put some of our effort. And there are really 4 targeted areas that we want: social determinants of health, mental health, and substance use screenings. If you don't ask the question, you will never find out the answer. So if we can implement these screenings, we will get more answers. Brief interventions. If somebody is in crisis in the physician's office, you want to be able to do something about that right there. You don't want to say, oh, wait 6 months and I'll refer you out. You want to be able to have someone around. And navigation to services. I mentioned those complicated systems that we all work in, and we want to be able to help navigate those systems. And then finally, extra contacts and warm handoffs, and just having that extra person say, hey, you mentioned that you're having trouble with food. Let me walk you down the hall and hand you to someone who can help you fill out that application right now. Not, here's the website, go figure it out. We want to be able to do that.
Addie, can I interrupt you? Are you okay with questions now, or do you want to wait till
You can ask questions now.
Okay. Addie and Addie, Art, and then Alyssa, and then Brian.
I just
And
mean,
Tom.
anxiety.
Okay, good.
Almost. Who's getting screened here? Who is screening?
The goal is for all the patients who walk into a patient-centered medical home related to receive a screen, to ask the questions of everyone. And those will vary. I mean, we can't implement that overnight, of course, but if someone's there for a physical, ask the question. If someone's there and you haven't seen them in a year, ask the question anyway.
Who's asking the question?
Okay.
Sorry, and we've talked about this before too, because the person can refuse, they can choose not to be screened. In some settings, it's a kiosk that they use. In some settings, it's something within their, what we call the electronic health record, that they can answer the questions online in the privacy of their home beforehand. Sometimes it's someone actually with a piece of paper having them do it. And sometimes it's actually someone with a computer in front of them asking them questions. So it varies from practice to practice who's doing it. Usually it's about once a year.
Is it a standard form that's used everywhere, or?
We're making recommendations in year 2 for nationally standardized forms that have been supported by evidence to be the right question and asked in the right way. That's what we're doing in year 2, is we're making recommendations for what those could be.
Okay, yeah, all right. Thank you.
So my question is sort of around the data, the numbers between the blueprint and the non-blueprint. So at this point, I mean, Medicare, Medicaid, Blue Cross Blue Shield, MVP, Cigna. That's a pretty large swath of attributed patients across the whole state of Vermont.
Yes.
So what percentage of Vermonters are attributed lives are attributed to the blueprint versus non-attributed?
About 60% are blueprint attributed, and that fluctuates from year to year. People go on and off insurers, and some insurers have better algorithms for deciding, which visits to count, which visits not to count. And we do have some small insurers, and we have some uninsured Vermonters that don't even try to calculate whether or not their patients would be attributed to.
So, and the per member, because the per member per year medical pharmacy claims cost, that's pretty huge.
Yeah.
Big disparity between the two. I'm assuming that these costs are what the actual reimbursements were, not necessarily.
This is the claims cost.
That's the
This is
claims.
Claims billed amount. And
the bill amount.
Yeah, the billed amount. And the reimbursement rates vary depending on the doctor, not just the insurer.
Yeah.
Which means that some places they will reimburse, and this cost is reflective. I did these numbers recently. The data we were given was claims costs when we first got this extract. So I'm newer on the other stuff. For example, Medicare, Medicaid, I believe the actual dollar value of savings is somewhere around $1,800 per person per year. So that because of the reimbursement rate is a little bit less.
Okay. Well, that's good to know that it was actually the
It's still positive.
cost.
Yes.
No, that's really positive. What is the difference in the number of claims? Like
Total number of claims.
total number of claims, what is the difference between the two?
So not everyone has a claim every year, of course, but some people have many claims. And the difference in claims is not as big as you'd fear. I was initially afraid, I'm like, well, the blueprint's big and we have 131 practices and maybe our group is tiny. And it turns out it's not. They're not quite equal, but the difference is less than 10,000. So in the total vein of all the claims submitted in Vermont, this is a small amount that I'm not too worried about.
Is the data extracted of where they're seeing their medical home? So do you know the number of, see, everybody always talks about, oh, this is great, number of claims are down. But to me, like when number of claims go down, I'm like, ooh, that's people not getting care.
Right, why?
Why?
So the number of claims, do I know where the claims are? I don't have that detail. So we pulled the dollar value, we said, the query I set up, and that was set up for this data extract before I got involved, was the count, add up all dollar values of all claims for any patient on this list. And this list is the attribution method in the Blueprint manual that the insurers run based on the all claims database. So they ran that attribution method, they added up all the dollar values of the claims for all those people. So I don't have claims specific, like this many were this diagnosis code, this many were at this practitioner. I don't have that specific value. That's what you're
That
at.
would have been a much bigger endeavor. So I did as much as I could with what we had to get this far, but that would have been a much bigger data extract.
I'm just thinking about the number of claims that people have seen their medical home. And my big concern with the all payer model was always, you know, when you're paying for quality and the provider's getting the same amount regardless, that provider is going to start attributing more lives to them and seeing their patients less, which is not necessarily a good thing either.
Data on that
Do
you
we
presented
have-
coming up in terms of blueprint, versus non-blueprint and visits. I think that's still coming.
Okay.
Yes, yeah, we have some visit
Trying
data
to share
that
that
we're
with
working on, but that, so we haven't seen that. We've actually seen instead a different, just a trend that I picked up out of this data extract is that the number of attributed lives that Blueprint practice has gone down a little bit over the past 4 years. So, and that's due to practices closing, but it's also due, it appears to be due to the fact that we do have an expiration date on how you attribute. So if somebody's attributed, they can't be counted as attributed if they haven't seen them for 5 years. They have to be within the past 2 years. If you have, and then so somebody who was seen in 2020 is no longer counted as an attributed patient. The attribution algorithm kind of tries to prevent people from just counting more folks as Blueprint and not seeing them. It's based on whether or not they had a visit with a particular diagnosis code in the past 2 years.
Great.
Thank you.
Okay, we have two more, I think, Brian and then Topper.
I have a few questions. I'll try to not take too much time, but so the first one is what is there any explanation or reason or hypothesis why people are visiting the emergency rooms less when they are connected with a Blueprint practice?
This is a great question. And I hesitate to speculate too much on reasons for anything because I don't have those reasons. But there's some varying topics. I mean, if you have a patient-centered medical home that has a community health team, and say you're in a mental health crisis and you know that person, maybe you call them instead of going to the ED. Maybe that community health team provides an extra resources. Some of our community health team's members are licensed counselors, so they can provide that extra resource and they might not need to feel like they visit the ED because they have this phone number they know they can call. Things like that could be a reason. I hesitate to say, oh,
Yeah.
let me guess.
And it's
But-
consistent with previous external and internal evaluations done of the blueprint showing the effectiveness of advanced primary care in conjunction with community health teams. It's also consistent with what New York State sees for their patient-centered medical homes. So we think that those are the two things that make the biggest difference.
Okay, that makes sense. So having a multidisciplinary team and the patient being familiar with that,
Right. They
using
know-
that resource, then they can provide other interventions before a person ends up in the ED. Okay.
And the community health team services are available to people of any insurance type or no insurance type. There's not a copay. There's a financial barrier for community health team interaction that's not there. There's not a financial barrier.
Does the community health center in Burlington, is that a Blueprint practice?
Absolutely,
Yes.
yeah.
I think that's good to know, because next time I need help, I'm gonna call them and say, can I talk to someone on the community health team so I don't
Yes.
get charged $150?
That's
All right, so thank
there's
you.
limits, but yeah.
Okay, so that being said, when we talk, I saw, you were talking about partners with the community health teams, and I think I saw it said designated agencies is one of them. Is there ways that private practices can connect better with the community health teams and be part of this?
So we have many private practices that have a community health team member
Okay.
embedded in them already.
Okay.
Once they become a Blueprint practice, and that's part of where I will go in just a minute, but
Okay, all right.
Yeah, you're talking about private mental health.
That's what I was thinking,
Right,
but
so-
this is still useful to hear, so,
Yeah, and we do, and that's in our handout
Yeah,
too, that
you'll
Addie
see a
created,
couple
there's some
different-
pretty creative things
Okay.
going on in some parts of the state of linking up with some of the multi-provider private practices to actually incorporate them into the community health team expansion.
I'll look at that further.
Sure,
We don't
yeah.
take too much time now. Then there was we were looking at the rest of them have to do with the training section. There was one that said lethal substances. What is that about?
I think that has to probably do with xylazine and also doses of
Okay.
medications that's it.
So maybe even like giving people supplies on how to test substances to see if there's lethal substances in them.
You know, we invite speakers and we have a whole range of speakers who make their expert recommendations, and some are on different sides, and we try to present the views that they have. But yes, that is something some of our speakers have presented, absolutely.
Okay, then we're almost there, so thank you. I'm trying to be quick. With the trainings that you provide, are they only for the community health teams and associated practices, or can they be for all healthcare providers? And could legislators attend if
They're
interested?
free, they're for all healthcare providers. It's just a matter of entering one's name and email address onto our CARES.
I'm not a
series
healthcare
page.
provider.
They're free, they're user offered. Yes, the link, I think the link is in our handout
It
as
is.
well.
Yes.
All
And
right,
it's certainly on our Blueprint website.
and then the last but not least, training question, are members, I'm trying to think of the word, like, are the providers associated with the community health teams getting training in CAMS, do you know?
We actually, so complementary alternative
Yeah.
medicine.
No, CAMS, in this sense is collaborative assessment and management of suicidality. It's like current kind of
It's
the current evidence-based training that's rolling out with the DAs and with private practices. I'm curious like how that might fit into the.
I think that's part of we have a number of requests in our RFP about different
Okay,
suicide management techniques and suicidality and screenings and things. So I think that's one of the things on the very long list of what we want
Yeah,
in
we have
those
a super
16
long list of
sections
everything
next.
we're asking for, so
Okay.
if it's not there, please tell me.
Yeah.
all right, thank you. Thanks for answering all my questions.
Yeah, on the slide that you have up there, it talks about expanding the teams to provide certain services. I understand what the last three are, but I do not understand the part that says social determinants of health, mental health screenings. We talking about somebody with a piece of paper screening somebody?
It might be somebody with a piece of paper. It could be that if somebody screens positive due to a piece of paper, or even sometimes a screening will be given to a patient and they'll do it on their own, and then somebody will review it, look over and say, oh, maybe I should talk to you about this. Kind of different options of how the screening will go in. And by expanding community health team, we add another person around, because trying to screen all your patients, trying to read all these pieces of paper is a lot of work. We can't expect the doctor to do it all himself or herself. So we would have maybe a community health worker will be involved in the mix, and they will be the person who's actually doing the screening or help reading the results of it and navigating that person to the next step.
How do you differentiate from social determinants of health and mental health?
So these we consider two separate things. Social determinants of health would be one type of screening, mental health is another type of screening, and substance use is a third type of screening. So social determinants of health can be things like, how easy is it for the person to get groceries? You know, if somebody doesn't have a car and lives in Chelsea, it's a little bit hard to get to a grocery store. Living near there, I know that. How easy is it for them to, go to work in the morning? Do they have big financial concerns? So social determinants of health are kind of this whole area of things that surround you that impact your health, even if you might not think about it on the regular. Whereas mental health is things like, are you feeling sad or down a lot? Are you feeling like you would be better off if you didn't wake up tomorrow? Things like that. help?
And I just say, go ahead.
I was just gonna say, I just talked to my 17-year-old to the doctors and we had this bunch of questions like, have you had any problems getting a meal this week? Or those the kinds of screening
Yes,
questions.
so that would
And I had
be,
never seen those before, like those types, and I was like, I wonder if these are those. So, and it was,
sorry.
no, it's great. I was
No,
thankful
no,
that they were
they-
asking, or like, have you ever experienced any vulnerability of having housing? And
Right.
like, I had not, so those were the questions that she was, and then I just thought, wow, I think that's what this is. So,
Yes,
Yeah.
you have just experienced it.
Okay.
Yes. I think we're good. Thank you. Any other questions? All right, so I will go on a little bit and tell you kind of where we are with the update. So who is participating? How many of them? We have an 88% participation rate from all of our practices, which we're thrilled with because if anyone's tried to get anyone to do something, getting 88% of them is great. So practices attested to incorporating these additional screenings, the ones that Melanie just saw in her life, and as well as embedding the staff members that we will fund and are funded. And we had some practices that said, no, we can't do that. And some of them said, no, we can't do that. I'm retiring in a year. That's a pretty good reason to say no thanks. We had some who said our electronic medical record system just can't handle that this year. Things like that. So we were really careful to make sure that year one is ongoing and year two, if somebody didn't come on board for year one, they can still come on board for year two. So a practice can say, hey, we got our electronic medical record updated. I guess we're ready for that. And so they can still sign on. So hopefully this rate increases. Even if it doesn't, we're pretty happy that we have so many people going on. Is that a question? Or are you just thinking? Okay. And the attesting practices receive additional staff. They receive support from our quality improvement facilitators, things like that. So when we were designing the expansion, we wanted to say, well, we want to put staff out there. Goals that we had were to embed a staff member in as many practices as possible, and to base that number off of Medicaid attributed lives as kind of a proxy for total patients, because I can get access to the Medicaid database a lot faster than I can get access to everybody else's for updating attributions. We wanted to use increments of a half a FTE is full-time equivalent, so a half-time position, a full-time position, or 1.5 time positions. Because if you say, hey, I want to hire you for 3 hours a week, harder to hire someone for that kind of job. And we wanted to include resources for practices that might be too small to get a whole person or even a half staff member themselves. You know, the one doctor practice might not really be ready to support another whole person. So we wanted to make sure those people were not left out in the cold. We also, of course, had a budget and we had to stay under it. And we wanted to make our salaries commensurate with the work we wanted these people to do. So all of those things kind of rolled together into that payment model that John mentioned. And that allowed us to fund a total of 82 full-time equivalent positions. So some of them are, 6 half-time here and 8 half-time there. We have funding available for what we call centralized resources, which in a health service area, if you have a couple small practices, they might all share one person. It might be somebody they can reach on the phone and say, oh, I, can't get you in, right now, but let me give you this phone number. We'll call you and connect you right this second with somebody who can help you with that. To date, we have 55 different individuals hired for 36 and almost a half now FTE, which is a lot. And we have a huge array of staff. And I'm really quite pleased with the graph on the right that you'll see. It just tells you community health team staff. The light blue bars are the existing, and then the dark blue is what this expansion has added to it. So you'll see we've bumped the care coordination up a bit. A care coordinator is somebody who, transitions of care, medication management, all these things that surround what happens when you have a condition that needs managing. A social worker, we've increased that by about 20%. Social workers involved in our practices, mental health and substance use clinicians, psychologists, licensed counselors, things like that. That's a little harder, so it's a little smaller bar. There's not as many of them, but we have increased that almost up to 20, which is we're really quite excited about. And then the big one is the community health workers. So community health worker is a person with lived experience who can really connect with the patients at their level, at their place, and say, hey, I know what it's like to apply for food stamps. It's not the end of the world. It doesn't make you a bad person. I've done it. Let me help you do it. Something like that would be a great example. And that we've really moved the needle on. We've got almost 4 times as many now as we had before the expansion. It's huge. It really helps, especially with that social determinants of health screenings as we implement those. community health workers are the people who can address that. I thought I saw a hand go up.
Yeah, funding, we have funding for 82 positions. Was that from the bill last year?
Yes, that is your work.
No, it isn't. Okay, and that funds come from,
They come from the Medicaid general and the general fund right now.
Yeah.
That's where they are from
All right.
right now. And that is our budget for the next year and a half here.
Right, that was the purpose of the blueprint expansion,
what bill was that?
is the budget. We voted on as part of our budget. Fine,
This would hopefully is an easy one. Are those licensed clinical social workers? Are those master's level social workers? Are they just people calling them social workers even without the training?
So they are some of all of these categories. Most of them are master's level or licensed.
Okay.
And that's because our portal has a category that selects the job title and then they have to select a credential next to it. So I have two different places to pull that information from.
But they are trained in social work.
Yes, they are social workers in that sense. And some of them may be serving in other roles. So they might be like, I'm a licensed social worker, but I'm actually a care coordinator. So it's hard to tell where in those categories they fall.
Thank you. And I also just want to express appreciation that for the inclusion of lived experience in this model that you mentioned.
We were very enthusiastic about that as well. So thank you.
we have one more, Addie, Daisy.
I'm assuming these are all Medicaid reimbursable positions.
So no, community health team positions are not billable services. They provide all their services for free. And so they are not reimbursable. They are paid through the budget that was passed last year. Their salary is paid exclusively through Blueprint funds.
General fund.
So we can, and we can walk through the funding again, and there's some that's paid for by the carriers, right, the payers.
Right, and so for the expansion, none of
None of that,
None of
okay,
it.
expansion is just the general
Right, so
fund.
those dark blue
That's-
bars are just
Okay.
the funds that were appropriated last year.
Right.
Yeah.
Okay, and then the plan would be, at the end of the expansion, is this working? What's the success? Is it something that we need to roll in permanently? And then it would roll to the payment, hopefully process, which is Medicaid pays, Medicare pays, and commercial insurance pay.
Right. So our hope is eventually we will expand the expansion. If I
Yes.
can. So speaking of that, is it working question, I think this is a very valid one, is one of the things we have was the story came into us from one of our licensed clinical social workers on a community health team. They sent a note saying, this is what the expansion has done for us. And she says, I just met with a patient who was here for a follow-up. She was screened for depression and suicide and was positive on both. I went in to meet with her and was able to connect her to another CHT member to address the underlying causes for depression and later connect about who might be a good therapist. And the fun part is that's just a day in the life. And then the part of this that was really impactful is that she had said she has never shared these thoughts or feelings with others, but because we asked the questions, she did. And that's that screening process is if you don't ask, you really don't know. Maybe you've seen this patient for 20 years, but you really don't know how they're feeling because you come in, you take the blood pressure, you say you're good, go home. And that's why we're asking. So it's a really heartwarming story of like, oh, somebody noticed. We also have some evaluation plans because we do want to come back and say this worked, this didn't work, it worked well, it didn't work as well as we hoped. We have 2 external evaluations. We have contractors working on those, and they've all started work. We have a qualitative evaluation, which will be conducted over 2 years, including focus groups, interviews, surveys, patients, families, caregivers, admin entities, administrators who implemented the program, anyone and everyone we can talk to, basically. And so our qualitative contractor is Market Decisions Research, and they are working on their interview guides as we speak. So that's an exciting step forward that'll be going on for the next 2 years. And we also have a quantitative evaluation, which will be conducted over the next 2 years that will analyze the claims data, anything we can get out of our BHI system, vital records, things like that, to really say what are the rates of mental health and substance use treatment and diagnoses and more of these kinds of things. And we also are doing some internal evaluations. Obviously, I love to do this stuff, so clearly I'm going to be involved. We had a CHT chart reviews that are conducted by our quality improvement facilitators or by designates in the practice. And it's a repeatable study that we can do regularly. We did one of them last fall, and we'll be doing another this fall to see what's happening on those CHT charts. Are we seeing those And we'll be tracking the CHT encounters and staffing through our portal. How many visits are we seeing? How many people are employed? All these different things. So that chart review I teased a little bit. I'm going to talk a little bit more about it. It was done from July through September of 2023. They pulled 5 charts from every CHT, which resulted in over 520 usable entries. And you always get a few that's like, oh, this person probably doesn't exist, or things like that. 71% of CHT patients had at least one positive screening result. So screening really does identify people who need to visit a CHT or can be helped through that. And they can, of course, refuse and say, I don't want your help. Anyone is allowed to do that. The average number of CHT encounters per patient was around 3. So they come, they visit again, they follow up, and then things are resolved and they move on for a little while. Reasons for CHT involvement, there were many on our list. I pulled out the top 5. And these percents won't add to 100. People can have multiple reasons. Some of them checked all of them. But mental health concerns were 2 of the top 5 reasons. The top reason and number 5, new mental health concerns, things that weren't around before.
And just to emphasize, this was before the pilot began.
Yes.
This is all.
This is the baseline. This is where it started.
Right?
I'm sorry to ask about this, but it just raised a red flag when you said sometimes there's a chart where you think this person doesn't exist.
So it's not so much that, it's that
Okay.
the data entered, when someone reviews a chart, they have a form they have to fill out.
Yeah.
And so if they flag, got no screenings, and then were positive on 7 screenings, I can't use that data.
I see what you're saying.
So
It's not like this phantom,
No, this-
like
no, this-
services or
this is-
fraud. Yeah, okay.
Right, I cannot use this
Right.
data. This chart is not valid
Okay.
for some reason.
That's fine.
Yeah.
I just wanted to clarify, because this, like, I know that my understanding is the fraud rate in Vermont is really low compared to other states, but like in the.
Yeah, no, we're not.
we get this
super fraud,
training
but
and,
if
like,
somebody's
you know.
filling out a chart, or they're
Okay.
like, someone is, simultaneously under 18 and over 18, I have
Yeah.
questions. We have.
Does that get flagged for the provider to look at and try to fix?
So that the QI facilitators will say things like, hey, go fix this one.
Okay, great.
I don't
Great.
review the charts myself, so I
Yeah.
cannot flag them because we have to blind the data, so I don't know who these
Yeah.
people are by the time it gets to me.
But someone is just letting the provider know there's an issue, because I think that also helps the provider if they ever get audited, if we're catching it in this process, to give them a heads up so they can look and be like, oops, we checked the wrong box.
Yeah,
Because I mean, like,
correction.
clawbacks is real with fraud and stuff, and anything we can do to prevent that.
Yes, yeah, so that's what I mean when I say some entries of our form are not quite useful.
Okay.
Other questions on this guy? So baseline CHT status, the light blue bars are before extension was implemented and the dark blue are after. And this is the patients as reported by the CHTs to us at Blueprint, how many they saw in a quarter. And so as you can see, we're seeing an uptick overall, and the uptick grows when the expansion was implemented. We have a few more bodies, we can handle a few more people. The last one is Q4 of 2023, and you'll notice that one is dashed because the data is incomplete. I don't have all my reports in yet from all my health service areas. So there's 2 of them outstanding. Last year at that time, they had 800 patients. If this trend is any sign, that bar is going to go up close to that 25,000 mark. So really are impacting, seeing a lot of people and seeing more than we used to. So it'll be fun to watch this next year when I come back and say, oh, look, it kept going up, or maybe it doesn't. We'll find out. And finally, I will turn it over to Alyssa Stahlberg to tell you about the Dulce part of the expansion.
Thank you very much, Eddie.
Thank you.
Great data.
Hi, everyone. Again, I'm Elisa Stolberg. I'm the Director of Family and Child Health at the Health Department. Last time I was here, I was the Director of Maternal and Child Health, the Health Department, but we've since changed our name.
What's the new name?
Family and Child Health.
It used to be maternal and child, now it's
Yes.
family. So it's more gender inclusive.
Exactly.
Okay, great.
Yeah.
Yeah.
We're leading the way in the country. So I'm really excited to talk to you today about Dulce. Dulce stands for the Developmental Understanding and Legal Collaboration for Everyone. And if you remember, this Dulce was a sort of a freestanding program at the Health Department that through the work last year was then incorporated sort of as in partnership under this Blueprint expansion. And so just a quick reminder on what Dulce is. So Dulce is a strategy to support families with very young infants in primary care. And so it's a multidisciplinary team that includes a family specialist who is an employee of the local parent-child center who works full-time in the pediatric practice. And they, that person sees every single family with an infant 0 to 6 months. In some cases, it's up to a year, and supports the family around sort of those social drivers of health, mental health, substance use, alongside the primary care provider. So they're present in the visit with the family and their pediatrician, nurse practitioner, whatnot. And they are working sort of on this kind of in an early relational health model. So they're coming alongside the family and supporting the family. And where there are where the family shares that they need some additional supports, they work in conjunction with the early childhood system of care, which already exists. They connect the family to services and resources. And unlike any program that we do, it's a universal program in the practice. So every single family is seen. So it's not families who just screen positive on a screening, or families that the provider has identified that they need additional supports. It's every single family. Obviously, families can opt out, but we have something like a 97% opt-in rate. So it's been very successful. I'm not going to read everything on this page all a lot, but this is really kind of the core of why Dulce is so important and so successful. It really is about, it helps to control those healthcare costs that, as you saw in some of the previous slides, really are kind of expanding in a way that maybe isn't best for anyone. And it really provides quality care and support for the family. It's incredibly innovative because it brings together the healthcare system and the social service system together in one point. It's not recreating some other system or recreating a system within the practice. It's actually bridging those things together. And in Vermont, we have a really strong parent-child center community, children's integrated services. And so this has been a really beautiful way in those communities to bridge those places. And again, it's a universal approach. So we're not singling out families, we're not targeting families, and we're identifying families who may not otherwise be identified. So we're not really making assumptions, right, that families may or may not need support. And so we're working across all families, and we're connecting them to services at a rate that is more impactful. Because the other thing that Dulce does is that there's a family specialist who's building a relationship with that family alongside the pediatric or the other healthcare team. And so there's someone that family can trust, and that trust is then enabling them potentially to connect with services in a way that they may not have.
Do you mind a question?
Not at all.
I just want to say I'm excited to hear this, and it's from a different perspective. When we were starting our family, we were an adopted family of an infant, and the amount of services that we didn't know about compared to someone that has a biological child was immense. So it's nice to hear about having all families have access to understanding how to be supported.
Absolutely. We also adopted our daughter, and I remember learning about all the Blue Cross services that you get during pregnancy that you don't get postpartum. So I can
So, but I really, there's so many ways that families need support. So
absolutely, yeah.
Art and then Brian.
Tell me what kind of things you do for these families. What do you do?
Sure. So every family, again, is screened for a whole number of social determinants of health and also mental
This
health.
is when the baby is born.
When the baby is born. So there's something like 6 scheduled visits between, baby born and 6 months of age.
They come to the house.
No, they meet the family at the pediatrician, at the healthcare
One person
appointment.
meets them or two? Or-
One person serves like a panel of 100, so depending on the size of the practice. And so every family is screened. They're not given a piece of paper in the waiting room necessarily. It's really the family specialist who's sort of coming alongside the family and asking asking questions, and depending on the results. So if the family identifies that they have a need for food supports, then they would connect them with the food supports. If the family is experiencing mental health, like if there's postpartum depression, then they would connect them with the services either in the community, or we have some supports at the health department that support that family. So it's tailored to whatever the needs of the family are.
Well, if there are no needs, you just send them on their way, or how does that work?
Well, we keep coming back so that they keep coming back. So those needs, either the family might not have needs, or they might not initially be willing to share that they have needs. And so we just sort of keep showing up. And if truly the family doesn't need anything in that moment in time, then they work with other families, but they're continuing to be available to them. Sure.
Frank?
Okay, so I did look ahead to make sure you're not about to, I've learned, to look ahead to make sure you're not about to answer the question. So I don't think you planned on answering this, but if so, I'm sorry.
No worries.
So I've been looking at the AHEAD model, that's coming out, and like the priorities of that. And we've been hearing that we might not have support for Blueprint if we don't play along and all this stuff. And so one of the elements of that model that I don't see you explicitly mentioning, but I bet you are working on it, so I wanted to ask, is health equity, because population health and controlling cost are two of the priorities of that new approach, but so is health equity. So I'm curious if you could say a little bit about how you might be promoting equity and addressing disparities through this work.
Sure. So I don't know. I know next to nothing about AHEAD. So I'm
Okay.
just going to talk about.
Yeah, you can leave that over there.
Yeah. So Dulce is developed by the Center for the Study of Social Policy. It's a national organization. And we are one of a number of states that have adopted Dulce. Dulce is described as an anti-racist approach. And so part of that is in that universal approach that families aren't singled out. Every family is offered this service. And so while that isn't the end all and be all of being anti-racist or achieving health equity, it's certainly like a really good place to start. And then and staff are trained in sort of health equity, and to ensure that they are approaching this work from a less biased place. But it's work that we're constantly doing. The health department is highly committed to health equity, and it's sort of infused in a lot of our work. And that sort of connection to services. The other thing about sort of the family specialist model is that that screening is done again in relationship, and that we know that that sort of screening outside of relationship can have a negative impact around equity, because there's when you're screening particularly young families, there's a lot of concern about that family when you are identifying as needing additional resources, or maybe not having enough resource to feed your family or provide those kinds of supports. Like that's a risky thing to stand up and say. And so the family, this model, Dulce, really helps kind of provide that kind of support for the family.
So I think it would be fair to say, if I had to summarize what I heard, that there's extra effort to promote inclusion. And so that's an important social determinant of health. And then And I am also hearing that there's a heightened awareness of looking for disparities in access to resources that promote health.
Yeah.
Okay, so that's good. That's great.
Yes,
That's what I said.
I'm gonna put that in my next slide.
Yeah, you said that basically in more
Yeah.
words, but I just want to be able to boil it down because then if someone asked, I could just say that
Yeah.
really easily, but that's great. And I appreciate what you're doing.
Thank you. Leslie?
I didn't look ahead, but I'm curious to know,
You should.
I know that it goes 0 to 6 months. What happens to the families when the children age out?
Well, and it sort of depends. Some practices kind of depending on the caseload will continue to work with some families if they have expressed sort of the need to keep going. But there is a transition, like families aren't just left high and dry. So there is a transition that happens to make sure that families are supported. But they're also transition to the early childhood system of care. So families who need additional supports might be enrolled in home visiting. And so they could continue to see families in their home up to age 2 or even now till 5 with our new model. Families might need early intervention supports. And so then they would go into early intervention. So the families who at 6 months continue to have some needs would be transitioned most likely into Children's Integrated Services and the others that exist in there.
Great, thank you.
So we have 6 practices that are 6 Dulce sites that are funded under the Blueprint expansion. The ones in black are those that are, I think they're black, can't really see, were funded originally by sort of an amalgam of other funding that we had and were transitioned into the Blueprint funding. And then we also at the Health Department have a federal grant called Transforming Pediatrics for Early Childhood, TPEC we call it, which is going to fund 3 new sites. And the federal funding was particularly interested in a health equity approach. And so that's part of the reason for the decisions around those 3 practices in red. And they sort of serve both kind of the New American and BIPOC populations in Burlington, Abenaki populations in Northwest Vermont, and then also St. J, which is the rural practice as well. And so we are that's a 5-year funding. We're now like in half of a year in. So depending on what happens with Blueprint expansion, it's possible that some of these practices could then come into that fold. And it's also allowing us to sort of test a few new things that there might be some adaptations we need to do, particularly around racial equity. And so we're kind of allows us a little flexibility to test. And then finally, Dulce is near and dear to our heart, but there's only obviously so much funding at the current moment to support it. And there are practices where Dulce may not be the right approach because it does expect a certain number of families with infants or young children in the practice. And in Vermont, we have some very small practices or family practices that maybe only see 20 or 30 babies a year. And so what we are doing in close partnership with our colleagues at Blueprint is really to think about how can we infuse the principles of Dulce into all pediatric practice across Vermont, 0 to 21. So we've started with the looking at 0 to age 6, so that early childhood spectrum. We're partnering with the parent-child centers and the American Academy of Pediatrics to really think about what would we hope to see around pediatrics in the blueprint. And so we're working on some shared training. The Dulce uses the touch points approach, which is this early relational health approach. And so how can we ensure that all practices sort of have access to that training? How are they trained on screening and developmental screening in the early, particularly the early childhood system of care? So maybe they're not a Dulce practice, but how do they work with their local parent-child center to make sure that families are referred? And we really hope to kind of create those structured partnerships to continue to be that bridge.
We have a couple questions, Mari, Topper, Leslie.
Mine's more for the end, so I can,
Okay.
you can skip over me.
Topper?
Mine's an easy one. How does this program coordinate with, I think it's called doula programs?
With doulas, is
Yeah.
that, yeah. So what we're trying to do again is to create this coordinated system of care. So so families may choose different kinds of support. So doulas are one kind of support that families may get, prenatally through the birth experience and then in the postpartum space. They may also choose to have home visiting, but they may just want the family support worker in the Dulce model. And so what we want to do is make sure that families sort of are driving the decisions of what kinds of supports that they need, but that's all coordinated together. So so a family who has expressed interest in doula services, which is spotty right now throughout the state, they would be connected. They could be connected through the Dulce family specialist to doula services. And so the best way to think about Dulce as an access point. So almost something like 95% of families get wild child care for their little kids, right? So it's the best way to reach families. And we don't have any kind of a connection point to families that's better than that. And so it's really just a way to connect with the family. It's not necessarily the service that they're receiving. So it's just that point to connect to the family and then provide the referral to services, of which doula services might be one of.
Is there, I see that your service is not active in central Vermont. Is that because they have a parent-child center there, a big one, and they have doula programs there?
No, it's really, they really want to do Dulce very much in central Vermont. And so we've been trying, they are sort of on the short list of practices that we would bring Dulce to next. Partly they have experienced a lot of turnover in their pediatric practice, which has made it a little bit challenging, but we're in conversation right now with Central Vermont and the Family Center of Washington County to figure out how we can bring Dulce there.
Yeah, because I didn't see that in here.
It's not there yet.
Actual sense.
It's in our hopes and dreams.
Leslie? Well, I hope this is in your hopes and dreams too. I come from the southern part of the state. We lost pediatric practices in Brattleboro.
Mm-hmm.
And of course, the rurality is a huge problem. And so I'm wondering how, and I know you're only in the pilot phase, and how, in your hopes and dreams, how do you imagine expanding this to where there aren't pediatric practices? I know I heard you say some practices don't see a lot of babies, but how do we approach that problem in a world of rurality and an absence of pediatrics?
Yeah, I mean, it's a big question. I know in Brattleboro, actually there's a partnership that's forming between the pediatric practice and the Winston Prouty Center. They're using actually their Blueprint expansion dollars to build that partnership. And so I think it's going to require a lot of some creativity and innovation, and probably isn't going to look the same in every part of the state. And so that's been some of our strategy. While Dulce is a sort of national model and we do it to fidelity, there's also a lot of space for innovation. And if you looked at the 6 existing Dulce sites, they all kind of run a little bit different, and they're all based on sort of how the practices run, what the parent-child center needs are. And so we envision sort of, especially through this blueprint pilot, to be able to work sort of region by region or even practice by practice to figure out what is the right mix and how do we design the partnerships there so that it works both for the practice and the parent-child center and the community. It's a little nuanced for sure.
All right. And then we're gonna move on.
If I look at this map, what percentage of families that have children are you working with in those areas where you have centers? Do you know, have any sense of it?
I don't actually know that offhand, but we could certainly get that information. You know, some regions have a multitude of pediatric practices, and some there's a single pediatric practice in that community, and maybe there's some family practices that also see a handful of kids. So, but we could certainly map out sort of how many kids are served through Dulce, and then maybe how many kids live in that region.
Yeah, I mean, you don't need it from me. I was just asking in general. And this is probably, fundamental to a lot of it. What problems are you trying to solve?
That's a great question. I mean, I think what we're trying to do, so the sort of philosophical approach around Dulce is that you have these bring on new babies and these brand new families. And really it's a very upstream prevention, support families now to get set up so that some of these other concerns that we're seeing down the road, I mean, that's why it's sort of paired with this blueprint expansion so that concerns about substance use and mental health and some of these other social drivers of health really don't that they can be addressed really on and supported. I forgot to mention sort of one of the key pillars of Dulce is that there's a legal partner. So Vermont Legal Aid sits at the table every week with the Dulce family specialists and the CIS team to run the list of families. And the legal partner doesn't actually they don't necessarily provide direct service to that family, but they're able to say, oh, you just said something about custody, or you just said something about concerns about housing. And so they're able to sort of intervene earlier so that they can see where there might be a legal challenge that could then set the family off course, in 6 months, a year, or several years. So it's really that really supporting families who, all of us who have young families really need support, right? And starting early on to set the kind of course.
So how long are you working with them? You may have mentioned this. How long do you work with these families?
So
like 6 months?
Yeah, so Dulce provides supports for for families with babies 0 to 6 months. In some cases, some of the practices go beyond that. But then there's a transition to the other support services that could, if the family needed.
And hopefully we set them on the right course so that later on there's not a problem.
Exactly.
Okay. All right.
Awesome. Thank you.
Are you done?
I'm done.
So it's Mari, go ahead, and then we'll move to John.
So I just have to comment that we work with a lot of really difficult issues in our committee. And I just so appreciate all of your work, and especially since you all seem really committed to what you're doing, and it shows, and I'm very grateful for it. And I love a data analyst who loves what they do. Thank you for your presentation.
Thank you. Thank you, Mari. Thank you. Appreciate it.
Home stretch?
Home stretch.
We can do this. All right. Lori was kind enough to let me include a few slides about cleanup, housekeeping, whatever the term is, related to statute that's been longstanding in the blueprint. And this is the beginning maybe of a conversation that we might continue, but I at least wanted to put in front of you what we're thinking and why.
And so if I can just add
Please, yeah.
for process, because our committee likes process. This would be something we could potentially do after discussion. If we have a bill that we could put it on that's germane, because I'm not going to try and squeeze this in before tomorrow. And I'm not going to try and squeeze it into the budget. But it's good to have the conversation, put it on the table, and then let's see what we can still get done this year.
And this is all very clearly spelled out because I'm not going to try to rush you all in a document that I submitted to Claire and Lori yesterday, which you all are certainly welcome to have. It's very detailed rationale for like almost every single word. So with that, there are some areas of our statute, what we call 709, that I've presented here after a lot of careful consideration with my team and leadership that relates to areas of that are no longer part of the blueprint. For example, chronic care management plan, and that's very much detailed in what I'm giving you. That the blueprint does not have the authority over, and really is rests more with the Vermont Chronic Care Initiative, which also submit their own annual report. And then there's also some language here, the results of healthcare professional and patient satisfaction surveys, language to strike out the fact that we have not surveyed healthcare professionals. We survey patients and people who are seen in them who speak for their healthcare settings, but there's just areas of this that have not been done and not been budgeted to be done. There's also the progress towards creating privacy and security protocols, which is very much held by our HIPAA rules, which we all fall under, which at the time this was written, it was probably pertinent to Blueprint, but is very much for not longer relevant, if I can be a bit blunt. So these changes would reduce some confusion between the Vermont Chronic Care Initiative and Blueprint. They would bring statute up to date with Blueprint's expanded focus on advanced primary care. They would update the status of the Blueprint from a forming program with progress reporting requirements to an established program with continued reporting needs. And they would account for some new policies that render that obsolete, that last mention that I said that was obsolete. We also included some other things that maybe, Lori, I can return to that are some grammatical updates and striking some language related to the fact that Blueprint's no longer a forming program. It's a well-established program. And this committee has taken so much interest and so much time in our central office staff, our field staff, presentations from others over this past year. It seemed like the right time to bring it up with you all. So there, I'll end it if that's okay. So I know you all have to be in your next place at 3:00 and take any other questions and really express our gratitude. It's been a professional opportunity of a lifetime to come this far. We still have a long way to go, but getting that type of investment and seriousness is taken to heart and to mind, and we're putting it into practice in place as best as we possibly can.
Right. And it's wonderful. I personally appreciate the data aspect of it and know that, we'll be able to now have this baseline and see what's happening with our investment to make some decisions further on. So any final questions?
Where's the language or the description of the proposed language changes?
I can leave this with you, or you all can just,
Yeah, I'll send it.
Thank you.
And we can talk later about vehicles.
If there's a vehicle, yeah. If we find that there's a vehicle, then we'll talk.
Okay,
about
but it sounds like there's interest in finding one if there is.
I want to make sure. You said you're going to send something out. We have a handout here.
Yeah, I don't think that's the language.
But that's not.
It's an additional send around that I wanted to bring it up with Chair Houghton first and then.
Yeah, if you can send it out, that'd be great, Claire. Great, any other questions for anyone on the team? Great, thank you all very much.